Hello everyone, welcome to the first episode of Shortly About Timpel EIT. The introduction. In this episode, we will briefly explore what makes the Timpel EIT monitor valuable in clinical practice. I created this video using my digital avatar instead of appearing personally. Although my native language is Czech, this technology allows me to effectively produce videos and localize content in over 100 languages for an international audience. EIT is a lung function monitor. It's bedside, non-invasive, and provides continuous and real-time feedback on ventilation strategies and their changes. In this introductory video, we will not go into detail about each tool that Timpel EIT offers. Instead, I will give you a general overview and highlight a few selected clinical applications that demonstrate its practical value. Timpel EIT applications extend across all phases of mechanical ventilation, from non-invasive support to controlled ventilation, assisted ventilation, and weaning. Monitoring ventilation distribution, tracking changes in lung volumes, and optimizing individual positioning strategies are valuable across all these phases. During non-invasive ventilation, EIT assists with NIV titration by providing feedback on NIV effectiveness and detecting pendelluft, complication that may lead to patient self-inflicted lung injury. In controlled ventilation, EIT enables precise PEEP titration by measuring percentages of overdistension and collapse at each PEEP level. VQ tool identifies lung perfusion defects and displays ventilation-perfusion coupling. During assisted ventilation, EIT detects breath stacking and quantifies its clinical impact using the asynchrony index. During weaning, EIT again contributes by detection of pendelluft, a known risk factor for weaning failure. Here you see the practical setup. Monitoring requires an EIT monitor and a correctly sized sensor belt. The sensor belt is covered by adhere, a single patient-use cover equipped with electroconductive gel. Measurements from proximal flow and pressure sensors enable the calculation of alveolar mechanics parameters, such as driving pressure. Mechanical ventilators typically provide only global averages of ventilation parameters. However, lungs are heterogeneous, and this heterogeneity increases when lungs become diseased. EIT continuously monitors regional lung function, providing deeper insights and enabling individualized ventilation management. The sensor belt has 32 electrodes and is applied around the thorax in a strict transversal plane, typically in the 4th to 5th intercostal space. Tomographical computing reconstructs a 2D image representing a 3D measurement covering about 65% of lung volume. With each inspiration, thoracic electrical impedance increases, and with each expiration, it decreases. This cyclic process generates an EIT plethysmogram, reflecting real-time changes in chest air volume. On the ventilation map, a color scale indicates regional ventilation. Gray represents areas without air volume changes. Dark blue indicates lower local ventilation, and light blue highlights the higher local ventilation. It is important to note that light blue areas are sometimes mistaken for overdistension, but in reality they represent regions with high regional ventilation. Overdistension, on the other hand, limits ventilation rather than enhancing it. The plethysmogram baseline represents end expiratory lung volume, and its amplitude indicates tidal volume. For example, increasing PEEP in healthy lungs leads to a rise in end expiratory lung volume, possibly with a slight reduction in amplitude, indicating mild lung distension. Increasing tidal volume visibly increases the plethysmogram amplitude. Now let's observe 4 illustrative scenarios of variability between tidal volume and end expiratory lung volume. An increase in tidal volume together with end expiratory lung volume may suggest ongoing lung recruitment. Decrease in tidal volume together with end expiratory lung volume may indicate progressing lung derecruitment. A decrease in tidal volume alongside an increase in end expiratory lung volume may indicate progressing overdistension. An increase in tidal volume with a decrease in end expiratory volume may indicate a reduction in overdistension. Ventilation distribution images can be segmented into quadrants, layers, right-left, or anterior-posterior regions. Quantifiable by percentage of ventilation distribution, allowing regional analysis. For instance, a slight increase in PEEP may show ongoing opening of the anterior left quadrant, while posterior left region may continue collapsing. When might such a situation occur? This is a real clinical case. Here, we observe differences in regional lung mechanics. One lung region, here dorsal, recruits, while another, here ventral, begins to close. It sounds a bit strange, right? This situation was recorded after proning the patient. So the dorsal region is now in a gravitationally non-dependent position, while the ventral region has become gravitationally dependent. To counteract this progressing closure, the PEEP level was increased from 8 to 10 centimeters of water based on feedback from the plethysmogram, stopping the decline and stabilizing the gravitationally dependent region. With the trend tool, we can analyze and compare two different time points up to 48 hours. What we see here is the effect of increased PEEP, leading to regional lung mechanics changes from a right lung and left lung perspective. The trend is visible on the right and left plethysmograms. On the ventilation change map, green indicates an increase in ventilation, while red indicates a decrease. Similarly, we can generate a map showing regional compliance changes, as illustrated here. But for each level of PEEP during decremental PEEP trial, PEEP titration tool quantifies the amount of collapsed and overdistended lung tissue expressed in percentages. In addition to this numerical representation, a regional map visualizes the distribution of overdistension and collapse. This allows clinicians to identify the PEEP setting that minimizes both collapse and overdistension and helps to decide the PEEP level and position individually for each patient. We return for the last time today to the plethysmogram, this time during the assisted phase of ventilation. Since you are observant, you may have noticed a reverse and double trigger, but also take a look at the plethysmogram, the first from the top. Do you see the variability in amplitude height? This indicates a situation where a reverse or double trigger causes breath stacking. This event is automatically detected by the monitor. But how significant is the problem? EIT measures both tidal volume during normal cycles and delivered tidal volume during breath stacking. The asynchrony index primarily quantifies patient-ventilator interaction quality. It has been documented that values above 10% are associated with increased mortality. The ventilation map provides an visualization of regional ventilation distribution. This is just a brief introduction, as an entire video will be dedicated to this topic. Ventilation can be either homogeneous, as seen in the first video, or heterogeneous, which can be categorized into two fundamental groups, spatial heterogeneity and temporal heterogeneity. One illustrative example of spatial heterogeneity is the dorsal hypoventilation phenotype, as shown in the video. For temporal heterogeneity, I have chosen the often discussed Pendeluft phenomenon as an illustrative example. When we know distribution of ventilation, wouldn't it be valuable to also assess distribution of lung perfusion? What do you think? Timpel EIT makes this possible bedside. During a short apneic pause, following a rapid injection of a 7.5% sodium chloride solution into a central venous catheter, we can observe blood flow passing in real time through the heart and its distribution in pulmonary vessels. This allows us to reconstruct a lung perfusion scan representing real blood flow distribution. When both the ventilation and perfusion distribution maps are available, assessing VQ coupling becomes the next logical step, and that is exactly what our tool is capable of doing. For practical use, we categorize VQ coupling into three groups on the map. Red represents low VQ, blue represents high VQ, and green represents clinically balanced VQ match. Several and different clinical applications emerge from this capability. The first is the detection of pulmonary embolism, which is why I have selected it as the initial example. This tool not only allows us to identify perfusion defects, but also facilitates bedside monitoring of the recanalization process, such as after thrombolytic therapy, and can be performed multiple times per day. Another pertinent example is the assessment of pulmonary shunting, which frequently contributes to hypoxemia in inflammatory lung diseases. EIT can identify pulmonary shunt regions as compartments exhibiting a low VQ ratio. thereby aiding in determining whether this complication is the primary cause of impaired oxygenation. As a final example, I have chosen a less conventional yet highly intriguing scenario. In this instance, dorsal atelectasis developing post-anesthesia triggered a pronounced hypoxic vasoconstriction reflex, culminating in pulmonary hypertension and hemodynamic instability. Elucidating the underlying etiology of this clinical situation enabled the implementation of an appropriate treatment strategy, resulting in a significant improvement in the patient's condition. Given its clinical relevance, lung perfusion and VQ deserves a separate dedicated video. And that's all for today. I hope you found this video insightful. This was just an introduction. More videos are on the way. In upcoming episodes, I will present the Timpel EIT tools and their practical applications. Thank you for watching. If you found this video helpful, please give it a like, subscribe to the channel, and leave a comment below. Your feedback is appreciated and helps us improve future content.